Assalamu alaikum, Sabah al-Khair. Good morning, everybody from Farah campus, healthcare campus in Amman. We are delivering this meeting about the case of craniopharyngioma, and then we'll discuss the issue of management of craniopharyngiomas. As you know, the theme of the meeting every Wednesday is correlation, to correlate the clinical, radiological, operative, and pathological findings. Our case for today is this 11-year-old male patient from Syria. He's one of the Syrian refugees in Jordan. He gave 2 months history of headaches and decreased visual acuity. And then he started to complain of polyuria, polydipsia, and some weight gain. Actually, polyuria, polydipsia, weight gain refer to one area, that is the third ventricle. He's a product of full-term pregnancy and normal vaginal delivery. There's no history of neonatal ICU admissions, and he has normal developmental milestones. Nothing significant in his past history except that he suffered from bronchial asthma, which was treated and it resolved at the age of 6 years. He has a sister, age 8 years. Vital signs were normal. That's the boy. A little bit of weight gain for his family. He wears glasses since the age of 6 years, and that's significant. Glasgow Coma scale was 15/15. His cranial nerves here, we are looking at the facial, that he can close his eyes and show his teeth. That's the facial nerve function is okay. As for the ophthalmology, we will discuss later, but basically he had major decrease in visual acuity on the right side. It's 5% on the right side, with optic disc swelling. And the OCT, which we'll also discuss, shows nerve fiber thinning, left more than the right, or right more than the left, sorry. This is his eye movements. We test each eye separately, right first, left next, and then we see the joint eye movements, because there are so many joint eye movements that are related to the frontal lobe and to the brainstem. Cerebellar signs were absent. His gait was normal. No sphincteric disturbances. No weakness in his upper or lower limbs, on the right or on the left side. And that's him. And he's raising his hands saying that I don't have weakness in my limbs. His CBC, bleeding profile, liver function, kidney functions were okay. Pituitary functions, because as I said, the polydipsia and polyuria with weight gain refers to something in the hypothalamus pituitary axis. His prolactin was slightly elevated, but not much. FSH and LH were very much decreased. Now, this could be related to his age. He's 11, but again, this is too much low. Urine osmolality was low. Serum osmolality was low. Specific gravity was 1.025, and he had the 12 BCs, the white BCs in his urine. The images, you look at this picture and your jaw drops down. This is the lesion that's in the lateral ventricle. It has moved up the foramen of Monro. It is located within the lateral ventricle, and it's reaching down to the foramen magnum. And the consistency is different. Look at this here, different from here, different from here, different from here, different from here. So this is an extensive lesion. And here we put you the T2 to see where are the cystic changes, where are the solid changes. And this is till you are occupying fully the third ventricle and you are going to the lateral ventricle. So many consistencies different. Here we are in the posterior fossa. This is brainstem, midbrain. There is no restriction on diffusion. And major part of the lesion is in the posterior fossa. This is right cerebellum, left cerebellum, and this is the lesion. This is the basilar artery. And he has hydrocephalus, active hydrocephalus with this periventricular lucencies, denoting that his hydrocephalus is active and it is high. And the major problem in the world in general, that these cases are left for the juniors, and once the juniors see something like this, they go for a shunt. We'll keep telling and saying that the best shunt is no shunt. Shunt is disaster for the patient and the family and the doctors. So don't put it unless it is necessary. However, lots of residency programs still teach the resident that shunt is an important. Still telling the patients that this is the best way to do that. Again, the coronal, we are here at the level of foramen of Monroe, and you can see the lesion from the foramen of Monroe to the foramen magnum. Same T1 with contrast and T2s. This is the MRA to see the relationship of the lesion and the MRV. And for me, MRA and MRV are part of the MRI. So I never ask for MRI. MRI is associated with MRA and MRV as one unit. What's the differential diagnosis of this lesion? We know this is craniopharyngioma. We're presenting a case of craniopharyngioma, but is this the only diagnosis? Pituitary adenomas, they can come as giant ones. And I have a very large series of these giant adenomas. Meningiomas, cellular, supracellular meningiomas, intracellular meningioma, they very much mimic our case. Germinomas, especially if there is a pineal lesion and a supracellular lesion. Histosarcoma, hamartoma of the hypothalamus, epidermoid. Teratoma, histocytosis, they love this area. They love the hypothalamus, the stalk, and the pituitary. Optic glioma, astrocytoma of the thalamus or the hypothalamus. Lymphoma, chordoma, plasmacytoma, single or multiple, sinonasal carcinoma, metastasis. I all keep saying, and it is just a repetition, these are my cases. They are not photos from books. These are real cases of mine. Sarcoidosis, aneurysm, osteoma, choroid plexus papilloma of the third ventricle, Rathke's pouch, Rathke's cyst, oligodendroglioma, just simple arachnoid, anesthesia neuroblastoma. So differential diagnosis is very wide. Preoperative investigation, chest X-ray and ECG were normal. We did a few consultations. This is the first consultation to Dr. Ghazi Saleh, neurologist, who did evoked potential, visual evoked potential, and he diagnosed right optic nerve impairment. The VER study was applied, head stimulation at a distance of 50 centimeters. The right P10 latency was prolonged when compared to the left. We asked the ophthalmologist, Dr. Suhaib Samadi, to see him. He's not here, so Dr. Ibrahim Sbeih will comment on that.
Good morning. So basically I'll talk about craniopharyngiomas in general and how do they present to the ophthalmologist. Most of the time, craniopharyngiomas come from the neurosurgeons. We don't see them as the primary doctor unless they have strabismus, because most of the time they have visual field defect, they have optic atrophy, they have papilledema, and a lot of kids, they don't recognize that they have visual impairment unless they start to bump into things or fall down. So basically, I've seen many of these cases from Dr. Sbeih, and usually they present with visual field defect in the form of bitemporal hemianopia, like the pituitary adenomas. But the pattern is different. Pituitary adenomas start from the above the visual field defect. Craniopharyngiomas start from below. So that's mainly. Actually, the tumors, they don't respect anatomy. They don't study medicine like us. So a lot of times they don't behave as we expect. So for example, in this case, we expect that a supracellular mass will be symmetric on the chiasm. It is not, because it's a lobulated, it's irregular mass. So there's a severe visual impairment in the right eye compared to the left eye. Bilateral visual field defect, I don't know, because I did not see the case. I don't know what is the defect. So yeah, I don't trust visual field automated perimetry in kids in a lot of time, because it's a difficult test, needs concentration, needs intelligence. So sometimes we don't depend on that in kids. We depend on more objective data. Right optic disc swelling, left optic disc pallor. That's what they found. That does not go with optic disc swelling to start with. ترى من شو رأيك؟ And does this go with optic disc swelling? I don't agree on the what they found. They felt that there is an optic disc swelling, but this is not an optic disc swelling. This is what we call optic disc atrophy. This is a 5th year medical student case. This is optic atrophy, and this is optic atrophy proved by objective data, which is the OCT. That's why we use the OCT to document things objectively. So this is bilateral optic atrophy, probably more in the right eye.
Okay.
Okay.
Probably from the pressure of the tumor on the
Yes. Yes. Also, we asked our endocrinologist, Dr. Muhammad Arnaout. Muhammad, are you here?
Are you home?
Please.
This is pre-op.
Yes.
We have done a pre-op workup for pituitary functions. As you can see, there is no major dysfunction in any of the axes of the pituitary pre-op. Labs? Okay. Yeah, it's okay.
Also, we consulted our pediatrician, Dr. Edward Al-Saqqa, who said he will follow the patient with our endocrinologist. Also, we consulted Dr. Ziad Mahadian, our neurologist, and he started him on Ipaneutin. And it's important here to mention to the residents about the Ipaneutin trough level. If a patient is taking 3 times daily, 8 o'clock, 4 o'clock in the afternoon, and 11 o'clock in the evening, the trough level should be taken 2 hours before the next dose. Otherwise, it will be misleading. Dr. Jamal Sharif, the anesthetist, announced the patient to be fit for general anesthesia. We got the consent form, which is in Arabic, of course, and it should take into details everything we have mentioned. I made a mark on this point saying that the patient before surgery is having a major visual problem, and he has optic atrophy, so he's practically blind. Practically blind is a very important legal term. And of course he has obesity, and he also has hydrocephalus. But I did not rush and put a shunt like crazy residents do. Even if it's an emergency, if it's an emergency in the middle of the night, put external drain. Do not put a shunt. Okay, we mentioned the complications in details and the signatures. So just a little bit of anatomy of the third ventricle, which is rather complicated, but once it is, you know the trick, it's easy. So this is the brain and the ventricles, lateral ventricle, third ventricle, fourth ventricle. We just isolated the ventricular system, the lateral ventricles, frontal horn, body, occipital horn, temporal horns, the third ventricle, foramen of Monroe, and then the aqueduct of Sylvius and the fourth ventricle. Again, magnification here. This usually you see it is where the two thalami meet. It's called interthalamic adhesions. And you put things in it. We put the thalamus in it. Here we put the brainstem in it, and here we put the cerebellum in it. So we will be working on this area, which is the third ventricle. And we have to differentiate between the thalamus and hypothalamus. So hypothalamus is this triangle. And you know how much it is? It's only 5 grams. 5 grams, which control your very existence of how you feed, how you temperature control, your heart rate, your urine output, your...
Higher center of autonomic nervous system.
It
The
is.
hypothalamus.
So it is the vital for everything. So this is a close-up view of this. This is the roof. This is the back of it. This is the floor. And part of the floor is sitting on the midbrain, and then you come to the medullary body, tuber cinerum, and then the epichiasm, lamina terminalis, anterior commissure, and so on. Roof, floor, anterior wall, posterior. So we have a roof, we have a floor to look at, we have the anterior wall, which is the lamina terminalis, we have the lateral wall, and we have the posterior wall. The roof is between the two crura of the fornix. If you open them, you will come to the tilla choroidi, and if you separate them, you will see the internal cerebral veins. Once you separate them, you are inside the third ventricle, as if you are looking from above. The floor, you see to the two mammillary bodies, the tuber cinerum, and then the fundibulum and the stalk. And so many vessels are there, and they are very important. So this is a very, very tricky area. Close-up view of the floor, as if you are looking at the base of the skull. This is the basilar artery dividing the two posterior cerebrals, the mammillary body on the right, mammillary body on the left, and then we have the area in front of them. That's where you do your third ventriculostomy in endoscopy. If you are looking from above, optic nerve, this is anterior, this is posterior, optic nerve, chiasm, and then you go, this is supraoptic recess, and this is where the floor of the third ventricle is, where you do the third ventriculostomy. These are the mammillary bodies, and then you are sitting on top of the midbrain. This is a cross cerebri. So this is the endoscopy view of the matter as you go backwards. This is the aqueduct of Sylvius, and here is the posterior commissure. So this is a view from endoscopy, mammillary body, you go here, you open it, and then you come to the basilar artery. The lateral wall, of course, the lateral wall here is made of the thalamus above and the hypothalamus below. This is the hypothalamus, this is the thalamus. And this is the 3D construction, optic nerve, chiasm, tract, and this is the third ventricle, the lateral wall, full of nuclei. 5 grams of your existence are there. Of course, a resident is not expected to know all these, but a consultant should, and I know each and every nucleus, what it does and what its function, etc. They are really arranged, they are not haphazard. And yesterday we were talking with Dr. Asura about the creation of God. If you see these things, how they are arranged, you would believe in God even if you are an atheist. The nuclei are arranged into paraventricular, medial, and lateral, from medial to lateral. And they are arranged in pairs, from anterior to lateral. So anterior, middle, and posterior, and then paraventricular, medial, and lateral. Each nucleus has a certain function. The anterior ones are the parasympathetic, the posterior ones are the sympathetic, and in between you have everything. The circadian rhythm, when you wake up and when you call, your sex life, your desires, your urine output, your temperature control, everything is there. So, operating in that area, you need to be an expert on that anatomy. Again, just to repeat what I'm saying, 3 grooves, paraventricular, medial, lateral, and then the extension anterior to posterior. 5 grams of hypothalamus. Anterior wall, a globe, optic nerve, the chiasm, the tract, and here is the anterior wall of the lateral ventricle. It is the lamina terminalis. Nerve, chiasm, tract, and here is the lamina terminalis. So that's the anterior wall. Again, this is how it looks at surgery. Optic nerve, chiasm, tract. This is where the lamina terminalis is. It's a rhomboid thing. This is a beautiful paper by my friend Tomasello from Italy, 2002. He described this rhomboid. It's a very small area. We're talking about millimeters. But if you know the trick, you can go there and you can do magic. The types of the lamina terminalis are different. They could be inclining backwards, they could be straight, bulging in, bulging out, but it's just the same. And this is the lamina terminalis, this is the nerve, this is the tubus aerium, infundibulum, the stalk, cerebropituitary, anterior pituitary, and this is the basilar. So when you come with endoscope, you come anterior to the medullary body, you open the floor of the third ventricle. It's magnification of the so mentioned. The posterior wall, of course, you have the pineal gland, the suprapineal recess, posterior commissure, and its recess. And of course, you have the internal cerebral vein and vein of Galen. Very dangerous area. Surgical approach in this particular case, which we are describing, this is the position of the patient. We call it transbasal interhemispheric. That's the incision. We raise a flap of the pericranium. We open the bone. We come across the superior sagittal sinus. We cut it the most anterior part. We go in between the hemispheres. We preserve olfactory tract. So these are the olfactory tracts. Optic nerve, this is the stalk. Anterior cerebral A1, A2, A1, A2, ACOM, and the lamina terminalis. Once you come to the optic chiasm, there are 3 types, so-called prefixed, normal, and postfixed. This is normal, it's some distance from the tuberculum silli. Prefixed means that it's going anterior. Postfixed, it means going posterior. Of course, you'd love to have this kind of thing because you have a space to go in. Here, this is the most difficult. And for this, it is ideal for lamina terminalis approach because you can go in here. So this is a normal chiasm. This is a prefixed chiasm. It's going anterior. There is no space here. And this is a postfixed chiasm, a good space. You can see the stalk going to the pituitary. This is how it looks at surgery. If you are coming from the right side, optic nerve left, optic nerve right, the chiasm. So you don't see the lamina terminalis properly. This is left, this is right, chiasm, and this is the lamina terminalis. Again here, left, right, and this is the lamina terminalis. So let's see the surgery of this patient, the Syrian boy. So we are separating the 2 hemispheres. As I said, it's called interhemispheric. So we'll separate the right hemisphere, which is on this side, from the left hemisphere, which is on this side. We are opening the arachnoid. Again, this needs patience, but the neurosurgery is all about patience and being meticulous. You don't give regards to the time. 6 hours, 10 hours, 14 hours, 18 hours, 22 hours, it doesn't matter. There's a job you want to do. Here we are trying to open the lamina terminalis. This is the lamina terminalis. You have to know where to open it, otherwise you'll damage the optic apparatus completely. And this patient is barely able to see. So this is the chiasm, and this is the lamina terminalis. We open it. There's nothing there, nothing to worry about. It's just a glial tissue. But if you open here, you cause major problem. Now, fluid will come out. Oily fluid, full of fat. And some people will say, hooray, we've just done the job. You have done nothing to the patient. This fluid is going to collect again within 2 weeks. So it's a crime just to take the cyst out. It's a major crime, in addition to the crime of putting a shunt. And people say, oh, craniopharyngiomas, they don't have a plane of cleavage. They are usually stuck. I'm against this principle. They are stuck, but by perseverance, you can find a plane of cleavage, and then you can take it out. Look at the fluid. Fluid is coming out, but this is not the story. The fluid is a product of this solid material that we are removing. And it has to be removed completely, not partly. So just go through it quickly. Mass after mass after mass. As you have seen on the MRI, it's extensive. Magnification, microscope. Don't trust any neurosurgeon who does not use the microscope. Neurosurgery is microscopic surgery, like ophthalmology. I can't see an ophthalmologist not using the microscope, and I can't see a neurosurgeon does not need use the microscope. So piece by piece, never in one piece. Sometimes it is really vascular, which makes things difficult and really cumbersome. Patience and perseverance. This is the life of a boy in your hands. His parents are waiting outside, counting the seconds. This is his best chance. Either you do it, or you will ruin his life forever by just taking a specimen, draining the fluid out, and put a shunt. And
ليش ما كان في early diagnosis for this patient?
because of ignorance of the family. This is the stalk, and the stalk is tumorous. You can see the tumor. So I don't hesitate 1 second of cutting the stalk. Stalk is part of the tumor, so keeping it is keeping part of the tumor.
Ignorance.
No hesitation whatsoever. If the stalk is tumorous, I just cut it, because my aim is radical excision of the tumor.
How would you protect the thalamus during surgery?
By having the experience of the anatomy and by working through the plane of cleavage.
I mean just by
Yeah, you can actually see a good plane of cleavage. But people don't want to waste time. They want to rush to the clinic to see patients or to whatever. So surgery should be quick. And you keep saying this, well, by the time I smoked my cigarette, the surgeon was out. This is rubbish. It does not apply in neurosurgery.
So you keep the capsule?
No, it has to be taken. Capsule is a tumor. So here we are having a glimpse of the basilar arteries, we are in the posterior fossa. And we have seen from the MRI that a major part of the tumor is in the posterior fossa. So we go anterior to the chiasm, and we go from the lamina terminalis. So we are attacking the tumor from both sides. If need be, I can go here, can go left, I can go anywhere I want. So this is a very good approach to achieve this. Again, patience. I think of this boy as my child. What can I do to save his life for a long period of time? This is a duty I have to accomplish. His family trusted me. They put their son's life in my hands. I cannot cheat them and go out and say we have removed it while I did not. So I'll just proceed. You pull from anterior to posterior, posterior to anterior, until you totally, completely take it out. And I call it delivery, like delivery of a baby. Like the mother who is screaming during delivery, once the baby is born, she's full of joy. I'm just the same. We use the ultrasonic aspirator because sometimes they have calcification and they're really very solid, and tough. And again, this machine is